Welcome back to the video series on fungi. In this, our second video, we will be discussing superficial fungal infections. First, a brief note on semantics. Even though sporotrichosis is being discussed with the superficial mycoses, it is technically a subcutaneous mycosis. Here is a more complete list of the superficial mycoses. We will not discuss all of these entities. First, let's discuss tinea versicolor, a condition with hypo or hyperpigmented patches of skin. The etiologic agent of tinea versicolor is the genus Malassezia. Currently, 12 species of lipophilic dimorphic fungi are known in the genus Malassezia. Malassezia invades the stratum corneum, the most superficial layer of the epidermis, particularly those areas with high sebaceous gland concentration. The reason Malassezia has a tropism for these areas with lots of sebaceous glands is because they are lipophilic or lipid-loving. They lack the ability to produce their own long-chain saturated fatty acids, so they depend on lipases to break down exogenous fatty acid sources. Tinea versicolor is also called pityriasis versicolor. The genus Malassezia is also associated with a number of other diseases. Malassezia exists as yeast in the normal cutaneous flora of 78 to 98% of healthy individuals. On the other hand, within the US, the prevalence of tinea versicolor is only between 2 and 8%. So what causes the Malassezia to go from yeast phases in the native flora to disease-causing mold forms in tinea versicolor? The reasons are unclear, but we do know that there are several predisposing factors for this conversion: humidity, follicular occlusions, hyperhidrosis, and immunosuppression being the major four. These risk factors are reflected in the higher prevalence rates we see in humid and tropical climates across the globe, where the rates of tinea versicolor may be as high in some areas as 50%. As the yeast proliferate in these predisposing conditions we mentioned earlier, they begin to transform into the mold phase. Also accompanying proliferation is the breakdown of more and more lipids. Lipid breakdown yields a number of metabolites that are very important in the pathogenesis of tinea versicolor. One metabolite in particular blocks UV light, almost like a sunscreen. Another inhibits tyrosinase. Tyrosinase is the limiting enzyme in melanin synthesis. In dark-skinned individuals, less UV light absorption by melanocytes and less melanin synthesis together yield hypopigmentation. In lighter-skinned individuals, or individuals with very few melanocytes, the small inflammatory response that accompanies this Malassezia proliferation results in a local hyperemia or redness that appears as a red-brown hyperpigmentation of skin. And so, the chief complaint in these patients is typically cosmetic. They're complaining of a change in skin color. The diagnosis of tinea versicolor is most commonly made clinically. Diagnosis may be supported with a yellow-orange fluorescence that occurs when you examine the affected skin underneath a Woods lamp. It may also be confirmed with a microscopic examination of affected skin, which has been prepared with a KOH prep. The fungi have a characteristic spaghetti and meatballs appearance, with a mixture of round yeasts and short hyphae mold forms. Other entities associated with Malassezia include Pityrosporum folliculitis. Pityrosporum folliculitis appears as numerous monomorphic 2 to 4 millimeter follicular papules and papulopustules with perifollicular erythema. It is very difficult to distinguish this entity from the much more common bacterial folliculitis. Disseminated Malassezia is a very rare entity that has only been described in premature neonates. Seborrheic dermatitis appears to be related to Malassezia infection, but the exact pathogenesis has not been clearly elucidated. Seborrheic dermatitis presents as sharply demarcated, yellow to red to brown, greasy, scaling patches and plaques over the scalp, ears, eyebrows, nasolabial folds, and other intertriginous areas. The condition improves with the eradication of Malassezia, though as we mentioned before, Malassezia's role in this entity is not clearly elucidated. You should focus the majority of your efforts into tinea versicolor. Topical therapy is ideal for localized or mild infections, but systemic treatment is often necessary for patients with recurrences or extensive disease. Continuing topical agents after clearance of tinea versicolor helps reduce recurrence rates. The next superficial fungal infection we'll discuss is caused by a group of organisms collectively known as the dermatophytes. This group of molds exists in 3 genera. These are not part of the native skin flora. These species invade keratinized structures of the skin, feeding off of extracellular keratin with proteolytic enzymes. They have tropisms for specific tissue sites, which correspond to the vernacular names, of which you're probably already aware. The medical names for these entities start with the word tinea, and then are followed by the Latin name for the part of the body they're infecting. Tinea capitis affects the head, tinea corporis affects the body, tinea barba affects the bearded area of the face, tinea cruris affects the groin, tinea pedis affects the feet, and tinea unguum affects the nails. They get the name tinea because they form round or serpiginous cutaneous lesions. Please remember that they are not in fact caused by parasitic worms. If they were, they wouldn't be in this video. Dermatophytes are most commonly transmitted either via person-to-person or via fomites. Examples of fomites would be hairbrushes or wet floors. Remember when your mother told you to always bring your shower shoes to the gym? Well, she was right. They can also be transmitted via animals to humans or from the soil. They are more common to occur in men than women, and this is because progesterone seems to inhibit dermatophytes. Dermatophytes exhibit a broad array of enzymes to help them adhere to the skin, hair, and nails. After adhering to the skin, the conidia quickly reproduce, forming a mycelium that invades the surrounding tissue. This is all aided by numerous proteolytic enzymes that continue to degrade and chew up the surrounding tissues. A slew of pro-inflammatory mediators are released, and these are ultimately responsible for the creation of these erythematous plaques. Cell-mediated immunity is important to prevent continued spread. Patients presenting with dermatophytosis complain of a dermatological disturbance and an intense pruritus. The individual tineas all present slightly differently, with location being their defining feature. There are many types of tinea. Tinea corporis is the name for any dermatophyte infection anywhere on the body, with the exception of those occurring on the palms, soles, and the groin. Tinea corporis has the classic annular or serpiginous morphology with a central clearing surrounded by a circumferential erythematous plaque. The clinical appearance of tinea capitis depends on the causative species and the host immune response. The non-inflammatory type causes scaly but usually reversible alopecia. The inflammatory type may be accompanied with follicular pustules and intense scarring that usually results in non-reversible alopecia if not treated quickly. Tinea favis, or chronic tinea capitis, is a tinea that invades the scalp, causing a chronic infection with yellow crusting and usually permanent alopecia secondary to severe scarring. Tinea barba, as the name implies, usually affects men in the areas of their beard. The most common mode of acquisition is from cattle or horses. There are superficial and inflammatory subtypes. Tinea cruris is a well-marginated annular plaque occurring in the crotch, usually bilaterally with scales. Tinea pedis has 3 different subtypes. There may be interdigital tinea pedis with macerated white scales and erosions between the toes, moccasin distribution of tinea pedis with patchy erythema and scaling in a moccasin distribution, or vesiculobullous tinea, with bulla occurring at various stages on the feet. Tinea pedis, notably, has also been well implicated for its relationship with lower extremity cellulitis. Strep and staph species gain entrance to the tissues through fissures in the toes. Tinea unguum may be distal, proximal, or superficial, and is usually very difficult to treat. Onychomycosis refers to a fungal infection of the nail, either from dermatophytes or other fungal species. Dermatophyte infections are most commonly diagnosed clinically. Sometimes a Wood's lamp is also used to support the diagnosis, though not all species of dermatophytes fluoresce. And of course, you can always examine skin scrapings in a KOH preparation, though this method frequently has a high false positive rate. Multiple options are available to treat dermatophytes. For most infections, topical options are tried first. Tinea unguum and Tinea capitis, however, as well as any other severe or refractory dermatophyte infection, require oral therapy. Oral therapy options include terbinafine, itraconazole, and fluconazole. Most texts list the alloamines as the preferred agent. Terbinafine reaches high concentrations in the hair and nails, and, unlike the azoles, it's not a strong CYP450 inhibitor. Now, if your head is spinning from all these pictures, push pause and review this slide. If not, let's move on to sporotrichosis. As the classic grim tale goes, Briar Rose was a beautiful princess who at a young age of 15 pricked her finger on a spindle and fell asleep for 100 years. But really, who pricks their finger on a spindle? So, in the medical version of this classic tale, we're going to change things around. In this version, Briar Rose is an unfortunately named second-year medical student. She lives in the Heights and she travels up to the Rose Gardens in Fort Tryon Park. Gets a little too friendly with the flowers and pricks her finger on what else? A rose. What happens next? Well, more on that in a minute. Sporothrix is a group of thermally dimorphic endemic fungi that are found worldwide in decaying vegetation. Sporotrichosis almost always occurs in cutaneous and subcutaneous tissues, so it is discussed here alongside the other superficial infections rather than during the video on endemic fungal infections that mostly involve the lung. Sporothrix infects people participating in outdoor activities like gardening. In addition to geophilic transmission, human-to-human and animal-to-human transmission also occurs. In addition to causing lymphocutaneous infection, Sporothrix also causes osteoarticular sporotrichosis involving the joint space. Pulmonary involvement of sporotrichosis is much less common and occurs almost exclusively in people with severe pre-existing lung disease. Disseminated sporotrichosis is also extremely rare and occurs only in markedly immunocompromised patients. Sporothrix gain access to the subcutaneous tissue following some traumatic inoculation. With the rose handler, the skin is pierced by a thorn, and the conidia then have direct access to the subcutaneous space. Once entered in the body, they have a high propensity to remain in the lymphatic system. Clinically, a small papule appears days or weeks after the initial inoculation. It may ulcerate, but this process does not tend to be painful. As the organisms travel through the lymphatic channels, subsequent linear erythema and a linear distribution of papules and nodules may appear more proximal on the affected limb. These too may ulcerate. While the diagnosis is frequently made clinically, the mold form of Sporothrix readily grow when incubated at room temperature. A biopsy of an infected lesion would reveal a mixed granulomatous and pyogenic response with scant cigar-shaped yeasts. In terms of treatment, you will be happy to know that there is one drug for the first-line treatment of sporotrichosis, itraconazole, though life-threatening illnesses are sometimes initially treated with amphotericin B before switching to itraconazole. That's it for the superficial and subcutaneous infections, but oh yeah, what happened to our young friend, Briar Rose? Well, that's up to you. You can let it be a choose-your-own-adventure book. Most likely, she, like all Columbia students, was oh so bright that she immediately knew what was going on when she saw the nodule, went in, got some itraconazole, and now she's a neurosurgeon making the big bucks. Or maybe she changed her name to Aurora and is now a surfing instructor in Hawaii. Think it over and get back to me later. See you for the next video.